cells. So when we look at the T cells here, again the 3 positive T cells are here. You have some NK T cell expansion, but you have a lot of cells which are 3 negative and 19 negative. So this red cell population here, you again identify the red cells over here. Surface 3 negative and 5 positive, right? So this is the cell population which becomes the population of interest. So this particular population exists. What about the rest of the T cells? They are showing the same patterns as they would show for a normal T cell expansion. So we gated the 5 positive, 3 negative cells. And when we look at 4 and 8, we realize that nearly all of them are positive for CD4. So 5 positive, 4 positive, 3 negative T cell expansion was there in the bone marrow. So this was the marrow that was assessed. When you look at CD7 in this pink population, you again realize that you have definitely a 7 negative component and a 7 positive component. 2 was homogeneously expressed. This case was acid for CD10. So peripheral blood also had Boule formation. So we were suspecting initially a plasma cell neoplasm, but then the plasma cells were polyclonal. So which T cell lymphoma can cause a lot of polyclonal gamma globulinemia, hypergamma-globulinemia? Angioimmunoblastic T cell lymphoma. So that was the suspicion. So therefore we did CD10. At that time we did not have all these other markers, CD279, 278, 185. These 4 markers, they are called as T follicular helper cell markers, the TFH markers, and you need 2 or more than 2 markers to be positive to call it a case of AITL. However, we gave it a possibility of AITL keeping in mind of the total picture. So this is an example of AITL where you have expression of 185, 278 and 279. And this is from Prashant's paper. I will show you briefly a last case. So this was in eosinophilia with skin rash. So how many of you received peripheral smears for eosinophilia? Everybody. How many of those eosinophilias you can find a parasite in? Very few, if you look at the percentage. What about the rest of them? So we advise a list of workup, exclude reactive, exclude parasites. Then if you have excluded reactive, excluded drugs, excluded XYZ thing, then you think of hematolymphoid. Then your clinician comes and tells you, I haven't found any translocation. So what should you do? You should flow them again. So again, lymphocytes. And these cases, mind you, have been acquired to about 3 lakh plus, 4 lakh plus events. If you acquire only 10, 20, 30,000 events, you will miss these small abnormal populations that may exist. So grossly, आप देखोगे 3-5 का plot looks normal, everything looks okay. But then there is a small population here, 5 positive, surface 3 negative. Now I've colored that population in blue. It shows up on all the plots. So that population appears to express only CD4, right? No 8. What about 5-2? That is normal. But what about CD7? The blue cells, they lack CD7. So they are 5 positive, but they lack 3, they lack 7, and they are expressing CD4 as well. So this is the phenotype that you frequently have in T lymphoid HES, hypereosinophilic syndrome, due to a small T cell clone. So now we did TRBC1. So TRBC1 also grossly everything looks okay. Everything looks fairly okay. These cells, as I told you, they are the gamma delta T cells, so they will not express TRBC1. Now we go back and we look at the 4 positive cells. So if we do the clonality assay, it seems that all of them are clonal. They lack the TRBC1 expression. But what do you need to remember? Surface 3 has to be positive for you to assess TRBC. In this case, surface 3 was negative in this population, so we will not use TRBC on the surface for clonality assessment. So this was a case of THES. This is the most frequent phenotype reported, persistent 3 negative 4 positive population or 3 negative and or more than 2% of total peripheral cells. This is an indolent disorder. The patient has to be given steroids, and most of the time the patient will respond with steroids and immunosuppression, but the patient can evolve to a T cell lymphoma. So now this is a case of ATLL, the classical clover leaf cells, and this is a T regulatory lymphoma. So you have CD4 and CD25 expression. So 4 expression as well as CD25 expression. And this is the summary. You can read this article. I'll be happy to share this slide with you. No problems. With that, thank you. And these are my acknowledgements. Not all cases. We have a direct cause, we don't need to, but otherwise we've made this a pattern. And slowly we are picking up cases. Earlier we were not, because possibly we were avoiding
to come for like report card.
persistent केस में पीका है जो एक शॉट स्टेरॉइड्स में नहीं हुआ है उससे तो आप कर रहे हैं.
We have learned about the machine, the fluidics, the pattern, the cases, the execution, CLPs. Actually, how do we sign out the report? It's not that everyone has their own custom made. There are some guidelines how to sign out that report. So flow cytometry is used as a tool to diagnose identified malignancy. However, there is disparity in reporting cases. Sometimes it is vague and imprecise. And the main purpose is we should be able to communicate the clinician. मतलब उन्हें क्या चाहिए? वो आपकी इतनी लंबी चौड़ी रिपोर्ट में से उन्हें क्या चाहिए? ठीक है? Okay. So the current guideline of reporting are based on 2006 Bethesda International Consensus Recommendation. These are basically for acute leukemia and CLPs. For PNH we have a different consensus. For MRD in like myeloma we have a different consensus. Okay, so we are basically what I am going to like in a few slides to tell you is about the acute and CLPD okay. These will be under 8 heads, like patient information, identification of the hospital, जहाँ से आपका sample आया, sample information, sample preparation, cell analysis, interpretation, flow cytometry, laboratory information, and lastly, any additional therapy. Patient information will include your name, age, gender, history, clinical information, provisional diagnosis, reason for flow cytometry request. Okay. Previous or current therapy. This is very important. Like you are running a CLPD, patient was on rituximab. Okay, after 29 because you don't have a history. We need a history. Previous, if there is any flow cytometry study done, okay, or other lab tests like CBC. Then identification of the hospital. Case कहाँ से आया? The referring physician. Okay, the referring institute. Sample information should include both on your requisition form and on your wire. There should not be any disparity. Okay, there should not be any mismatch. Okay, and it should include lab specimen number, reporting lab ID. जैसे अगर कोई UPHGCON आप फॉलो कर रहे हैं या लैब का आपका LIS है तो वो उस पर मेंशन होना चाहिए. ठीक है. सैंपल सोर्स ब्लड है, मैरो है, CSF है, प्यूरल फ्लूइड है ना. सैंपल डिस्क्रिप्शन, व्हाट इज द एंटीकोगुलेंट यूज, EDTA में सैंपल है या रेफरेंट में है. ओके. वॉल्यूम, कलर, टाइम एंड डेट ऑफ कलेक्शन एंड टाइम ऑफ डेट ऑफ रिसीविंग द सैंपल इनटू द लैब. Details about cell preparation. What was the methodology used for preparation of sample? Okay. Sterilized wall, which is the most common one. और bulk lyes और lyes stain wash, ठीक है. Sample preparation date and time, cellularity, cell viability, because अगर stored sample है और that sample has reached to you like from late पहुंचा है 2-3 दिन के बाद, you need to do a viability assay and you have to mention that in your report. Okay. Antibodies used, obviously, the panel used, the fluorochrome used, and whether they are surface or cytoplasm. Cell analysis. Okay. So quantitative description of light scatter, immunophenotypic features, लार्ज सेल थे, एबनॉर्मल सेल थे, ब्लास्ट थे या कुछ भी नहीं थे, ठीक है, नॉर्मल पॉपुलेशन था. फ्लोरेसेंट डिस्ट्रीब्यूशन इन टर्म्स ऑफ नेगेटिव, पॉजिटिव और पार्शियली एक्सप्रेस, ठीक है. देन फ्लोरेसेंट इंटेंसिटी, डिम है कि ब्राइट है कि हेटेरोजेनस है इन कंपैरिजन टू योर नॉर्मल इंटरनेट, ठीक है. जैसे हम CD10 देख रहे हैं ऑन अ बी सेल, तो यू कैन ऑलवेज कंपेयर विद न्यूट्रोफिल. इन न्यूट्रोफिल के कैसे इन कंपैरिजन टू न्यूट्रोफिल आपका जो सेल ऑफ इंटरेस्ट है उस पे कैसे, ठीक है. रिलेटिव काउंट, नॉर्मल सेल पॉपुलेशन है या नहीं है, ओके. इन केस ऑफ CLPDs kappa lambda रेशियो 4:8 रेशियो इन केस ऑफ अगर T सेल एनालिसिस के लिए आया हुआ है. एडिशनल कोई साइटोकेमिस्ट्री आपने किया हुआ है, अदर immunohistochemicals that is helpful in making the diagnosis, you mention that also in the report, and genetics. Then come the interpretation part. If there is no abnormal population, you will describe the normal population. Okay. And if there is abnormal population, you will describe the abnormal population. What is the phenotype? What is the WHO interpretation? Okay. And more definite diagnosis according to those interpretations. Any comment or disclaimer like your sample is not adequate or it is diluted, okay, you have to mention that. Limitations of the interpretation, like it's a case of mental cell leukemia, you need a cyclin, you cannot just take on a flow cytometry, you have to mention that the limitation of your test. Okay. And lastly, signature. Information about your lab. On the report, laboratory name, address, phone number, any licensing from CAP or CLIA. Additional elements, you can provide representative histograms. As many private labs they do provide you histograms. Recommendations for additional test and date and time of your final. And this is sometimes we see that like this is a report many times we come across these type of report in which they mention percentage, and this is not recommended. According to consensus, it is not recommended. Okay. So report must be customized to meet the local practice, but it should still contain the basic elements. It still contains the basic all the elements. Okay, to reduce the subjectivity. Okay. And this is a pattern of the reports which we are releasing from our lab. Like the upper part you can see is the unique identification number, patient name, age, sex, then sample collection time, referring department. Okay. Then you have what is your morphological diagnosis, what was the sample type, what was the instrument used, okay? Cell preparation method, your abnormal population, their expression, bright hair, heterogeneous hair, dim hair, then the mention of what was negative inputs. Okay, and then you sign out. If you want to mention some limitation, you can advise that these are the limitations which cannot be done on this, but these are suggestive of testing and advice. Okay. That's all. Thank you.
We will now proceed ahead to a different tab to see the sample processing. हम लोगों ने कल
those samples
Hello? Hello?
of Medical Sciences and International Union for Cancer. Formerly Senior Professor and Head Lab Sciences and Molecular Medicine, Army Hospital and RR Delhi and Hospital Medicine, AFMC Pune. And patients. Sir, we welcome you.
Sorry, these are all memories.
This switch on and what happen during the cycle is here.
Yes.
And
There's a project. Number one. No? Yes.
yes.
So once it's So I purposely given you some diluted bone marrows. Okay, good afternoon all of you. I've given you some diluted bone marrows, but those diluted bone marrows have got a plethora of information, which will be surprised. Okay? So the idea was that do not disregard diluted bone marrows. It's so difficult to do marrows. We do it. But marrow जब किया किसने ऐसा फालतू कोई marrow तो में करते नहीं. So try your best to see that marrow. Just as you see the FNAC slides, so many slides are full of blood. I still remember Dr. Anita Borji when I was training under her. So there was this testicular nodule, and I was doing postdoctoral fellowship, and there was JR who were doing MD there. So only blood. Now we had a system. Asked me, I was a captain those days. Dr. Ji asked me, Captain Chatterjee, you have marked something. There's only blood. Why are you wasting your time? So I knew that there was something because she is sarcasm ka hero. Instrument in your hand. You are physician yourself, and you have got the diagnosis. इसका बीटा ECG कितना है? Patient का नाम संजीव है. By the way, I had also forgotten the patient name Sanjeev. She remembered. Beta ECG कितना है? 15,000. It was a choriocarcinoma. So I came to know a small nodule in the test is very FNC. It is a hemorrhagic smear. But if you see those, she said, no, you don't have to impress. The reason you have diagnosed this is because our turnaround time is so much. Now I will admit this patient. So she takes me to the OPD. Sanjeev patient kaun hai? So 29-year-old young man comes. Sir, ma'am, she admits this patient. And then she says, I am not admitting for anything. This is the most radio in the giant cells. Had we not gone and seen the beta ECG, had we not admitted this patient, retroperitoneum, and day after 20 days, mediastinum. How great this lady is, and how great various doctors are in various colleges. Okay? So you have to have a clinical touch. Similarly, when I give a diluted marrow to you, when my faculty rang me up, कि ma'am ऐसा patient आया, diluted marrow है, and patient is not well. So I rang up the clinician. So my wife was saying, what the hell are you doing? Run of fetch में आया, उसके बाद तुम यहाँ से वहाँ बात कर रहे हो. I said, just give me 5 minutes. So rang up me without a bone marrow. Now what do you see in the peripheral smear? Anyone can describe? 6A.
Slide 6A, case number 1. The first case.
You can't see, blind as a bat. So if you cannot see this cell, you are blind as a bat. What is this cell? These are hairy cells. These are hairy cells. They're very classic. Okay? This is a very I think most of you will make it because this was the opening bat, So convince. Let's see a better field. Yeah. So they are essentially interlocking microvilli, isn't it? Hairy cells. And अच्छा अच्छा, इसको दबाना.
Yes, sir.
Okay. Has it come?
Yes, sir. Yes, sir.
Oh, 9 minutes. Is it okay now?
Yes.
A slide like this. Generally, hairy cell leukemia comes with pancytopenia, right? This is not pancytopenia. Okay, cells so are in TLC will be about 7-8,000. So it could be, because I did not tell it, you said it. So hairy cell variant is a misnomer, right? Because now we know it is a family of mantle cell lymphoma with a. So if you got this and you don't have a marrow, if you get a peripheral blood like this, you can still do a flow cytometry on the peripheral blood. So you put a तो biopsy में तो आप morphology करोगे, IHC करोगे, but if you got a peripheral blood with about 6,000 count, you can still do a flow cytometry. And what are the CLPD panel you would like to put in this? So you'd like to put a CD45 and a CD19 gate. You want to gate strongly CD19 positive, right? What else will this be positive? You can do a cytochemical stain called TRAP. Tartrate resistant acid reflux. Now this is absolutely a beautiful test, but not done because it has to interpretation. Plus, we have got a lot of other cells which can be TRAP positive. What are these cells? Gaucher cells. Gaucher cells can be TRAP positive. Various other cells, monocytes can be and monoblast can be TRAP positive. So TRAP. Now we have got an antibody, a monoclonal antibody to TRAP. So we can do a TRAP IHC, right? So anyway, so we do a flow before we do the bone marrow biopsy. Bone biopsy आएगा IHC होना पर उसी दिन अगर आपने flow कर दिया आपको bright scatter gating, you get a bright CD19 positive. You will get a CD20 positive. There is an antibody called FMC7. All CLPDs are FMC7 positivity negates a CL. This is how we were taught. The moment you get a FMC7 positive, it is not a CL in 98% cases. Rest of all the CLPDs are FMC7 positive. So you've done a CD19 gating, and you got a bright 19, bright 20, and then you got a. Then you put the specific markers. So you know it's a BCLPD. Then you could have given a diagnosis. Why? Because now we've got so many types of curative treatment. Which are the medicines you give in hairy cell leukemia? Clad. Right, we used to give cladribine infusion for 7 days. And the spleen, which was a massive splenomegaly, used to vanish. Nay, another CLPD with a massive splenomegaly, which can mimic hairy cell leukemia, but is not hairy cell. And Purana Zamana mein usko hum log surgery good. The SMZL mimics the hairy cell leukemia, except that it is villous lymphocytes, whereas hairy cell is banned. SMZL is, it is CD25 can be positive in 20% cases. Otherwise, CD25 is also negative. 11C is negative, 103 is negative. But what is more important today in the era of molecular meta, which is very BRAF. So the BRAF mutations, which you see in melanomas, the BRAF mutations are strongly positive in hairy cell, whereas in SLVL it is notch2 mutation, right? So these are basic caveats. So now with this in mind, have we made a tentative diagnosis of flow? We go to the so this is the biopsy. So if can someone describe this biopsy? Yeah, here it is. So you got the dark black cells and the vesicular cells, right? It's as simple as that. जब कोई biopsy देखते हैं, there's no point describing like that, no? जो देख रहे हो बताओ, isn't it? And this is the beauty of a thin section. So you do step sections, right? So in hairy cell leukemia, if you do a reticulin stain, you will get pericellular as well as inter-reticulin fibrils. The first special stain you're going to do that, you will say, sir, I would like to do a reticulin stain. and the examiner will be very much impressed. Don't go to prostate, pericellular. The von Giesenstein and all are negative. This is just reticulin fibers, right? What else you would like to do in this? You might see some sinusoids within which you are seeing hematopoiesis. So you can see intrasinusoidal hematopoiesis. You can see the IHC markers would you like to do in this? Now you've done flow. Now flow ka markers IHC mein nahi hai. So what IHC markers would you like to do in this? CD20. So you've done a CD20. You have said it's the DCLTD and so they are emanating from the margin. CD20 positive. And we know now the WHO has removed so many terms. Put in a basket diagnosis at E5 or 2020 plus is large lymphoma cells with prominent nucleoli. ठीक है? उसमें आपका pericell variant आता है. ठीक है? Even BPLL, the term BPLL, I have given you one. Lymphoma with prominent nucleoli. I don't know how this category has been made because it is a very vague term. It has got the CCND1 and CCND2 molecular defects. So it is more of a mantle cell lymphoma family. So they also do not behave well to the mantle cell leukemia and the hairy cell variant are now one. So the idea of giving you this slide is one, clinical practice, a patient with firm, massive splenomegaly, think of a CLPD. And you will get a picture something like this. You're surely going to get one question. And there are a lot of questions on the flow as well as IHC on this. Clear? So please do not say I like to do IHC first in a bone marrow. You have to do a reticulin. Okay? Next case. Seven, na? Very nice. Now see this case. What is the history? The pallor positive. That's interesting. HIV positive means Mamla Garbad hai. Something in the bone marrow has been involved because of HIV positive. Let's see. So when you see the slide, there's a straight away seeing fibrosis. Anna? First, let's go further. So you are seeing this cellular elements. You are seeing this element. We are going to see that also. Okay. Now see carefully. See? You want to focus here? So tell me, overall impression? See, you see the slide is stacked. You see the areas of normal cellularity, Hodgkin lymphoma with normal cells with myeloid cells. Then you see the dense inflammatory area. If you see just megakaryocytes and it says Hodgkin cells, तो गड़बड़ है ना? तो आपको myeloid cells तो मिलेंगे. Normal myelocytes, metamyelocytes, megakaryocytes, सब. Then very cellular. Go to the hyper, you see plasma cells, lymphocytes, eosinophils. In search for the classical weak stem cells. Have you seen this? See? See again. Inflammatory cells, inflammatory menu with fibrosis, eosinophils, बहुत कुछ है ना? But I will not search for this. Some will say here. These are megakaryocytes. This is normal marrow. So, showing a normal marrow element in various phases. However, Normal average में megakaryocytes है ये बोल दिया. Then coming to that, there are some foci of a dense inflammatory milieu in which are scattered the monomorphic and the myelonucleate. The mononucleate. Happy. In a lymph node diagnosis is already been made. Even if there is fibrosis, that the bone marrow is involved. So this is secondary fibrosis because of involvement. So you do step sections. You do step sections and you will find the reeds control cells. So two scenarios. One, आपके पास lymph node diagnosis हो गया. अगर आपको इस तरह का मिल गया, very good. अगर नहीं मिला, and you're getting fibrosis, then do step cuts. Fibrosis is an indication that something is going on secondary to the neoplastic. And if you do step cut, you'll get reached. One, there is one scenario when we were young, when ISCs were just about coming. We're not having ISCs. Okay? So we used to do those, we used to section cut or cut. So this is one scenario. Second scenario is you got a 15 and a 30. Now, if you do a 15 in a bone marrow biopsy ISC, you will be drowned in your misery. Why? Because 15 is positive in all the myeloid cells. You are likely to make a mistake. So 15 is never used in a bone marrow biopsy. However, 30, in 98% of Hodgkin's lymphoma, CD30 is positive. So the moment you get a CD30 positive with a Golgi zone accentuation, you are absolutely lymphoma. Yes, why not? Yes. In a history of HIV positivity, and I've got a history of an Hodgkin's lymphoma involving the bone marrow. However, clinically, please correlate, search for the lymph nodes. This is the bone marrow जहाँ lymph nodes हैं. Hodgkin's does not present like that. But then HIV positive, कुछ भी कर सकते हैं. Will come later because उसका immunodeficiency इतना हो गया, the lymph node react करने की force. Don't mistake these. These are your RS-like cells. The other cells you're seeing are all the inflammatory cells in this. These are your RS cells. So these are yours, which can be used with great perfection in the Hodgkin cells, right? And the whole thing is the inflammatory fibrosis. One antibody which has come in great bone marrow biopsy. FASCIN, FASCIN only will take the RS cells. It will not stay in the myeloid cells, the myelocytes, and all that thing. So FASCIN is negative. So you know this is MRD negative. That means patient responding. Now coming to the IHC. So have a look at this IHC. This was a rare case where we gave a primary diagnosis of Hodgkin's lymphoma bone marrow when we had not got the nodal diagnosis. And it was HIV positive. And the patient subsequently adopted massive nodes, retroperitoneal nodes. Hodgkin never presents with retroperitoneal nodes. But HIV positivity, sab kuch ho sakta. See? So this was your second case. I hope you are understanding a lot of lyrics, right? Classical hallmark cells, which are wreath-like cells with peripheral attachment of the nucleus to the cell. As if आपने wreath, you placed a wreath on a cadaver. So that's called wreath-like cells. They mimic Hodgkin cells. Peripheral T cell lymphoma, NOS. They mimic in the bone marrow. Negative आता है, LCL में. You got the CD30 will be diffuse positive. However, in Hodgkin lymphoma, it is membranous with a very Golgi zone accentuation. So the strong 15 negative, very important, PAX5. PAX5 is a B cell marker. The moment PAX5 is positive, it is Hodgkin's. ALCL is a T cell marker. So PAX5 will be negative. So there are a lot of situations. Yes, you're absolutely right. You must be aware of the mimics of RSS, particularly in a case like this, which is HIV positive, where you don't have a nodal. So you have to use what he rightly said, a panel of antibody. So if I have to have a primary diagnosis of this, I will use this. The CD3. CD3 negative, Hodgkin's. And then 15 and 30. And the difference of the staining of 30 in ALCL.
Streaming of this session on YouTube.
Oh, really?
Yes, sir.
I'm honored.
Yes, sir, we had, because I thought our residents also can hear from
Oh, sure.
wherever they are.
Very nice. Very nice. So we come to the third case, and this is again a very interesting case. 50-year-old male has pancytopenia for past 1 month. For 1 month, bone marrow aspiration was dry. So we got a biopsy. Now see this case. Very exciting case because you rarely see such cases. Lineage hematopoiesis, suddenly you see this. So you reduce the light. So this is a very exciting case. You're saying this is metastatic squamous carcinoma. You're saying intercellular bridges. You're saying keratin pearls. Normally you see adenocarcinomas. Bone marrow में colon से आया, breast से आया. ये head and surprising when I said, "Sorry, sir, are you sure?" मतलब deep section अभी I'm not sure यार. मैं कुछ गलत तो नहीं बोल रहा हूँ. Deep section क्या? आपको सकता है. So metastatic squamous cell carcinoma. This was the opening, है ना? Okay. So most of you got it correct, and this is a desmoplastic reaction. What you see here is a desmoplastic reaction. These are the metastatic squamous cell intercellular bridges and keratinizing pearls. Right? So this was a bounce actually. Next case is case 4. Now this is a very exciting case. 55-year-old male. Now see, this history is very important. 55-year-old adenomas are EGFR positive, so all the molecular mutations. So उसी paraffin block आपको देना है. So you cannot waste on ISCs. So the basic ISC you do is TTF1 and napsinin. आजकल दोनों भी नहीं करते. आप एक एडिनो कर दो और एक P40 कर दो. P40 स्क्वामस, TTF1 एडिनो. अगर आपका TTF1 पॉजिटिव हो गया, इससे ज्यादा क्लिनिशियन आपसे पूछेगा नहीं. सीधा पैराफिन लेकर मॉलिक्यूल में भागेगा. PD-L1, anti-PD-L1, nivolumab and all that thing. And after 2 years of treatment, this patient sinks, but by the time the lab has made another medicine. So he's giving you time. So this is a commercial circle they have. So anyway, why I'm telling you this? Because maybe the corresponding antibodies will develop and you'll be putting that in your tissues as well as biopsies. So anti-PD-L1, now we are standardizing that. It is not a surrogate marker for what we do in fish or molecular. What the clinicians and the patients are demanding because of precision medicine. So coming to put on alkylating chemo. Cytopenia. So that's how I came. Aspirate was grossly diluted. I've got nothing with me except the biopsy. Now see how things change. Again a good biopsy. What is the कितना उम्र है इसका? 55 तो 50% ज़्यादा है. Age. The normal age. Unilobated. What about these? These are all blasts. These are all myeloid blasts. So what has this been? So you've seen hyper now, see. All blasts. So you do an anti-M. Therapy related. Alkylating agent use किया 2 साल बाद उसका AML lung था. Now double WHO AML classification. And never again think of 5Q. 5Q is a very simple होता है, cellulite normal होता है, and patient is absolutely well controlled. You will not get blast. These are all AML blasts. So this is therapy or secondary AML post.
So we can think of infiltration of the cell.
Who's it? Yeah, tell me. So the adenoplasm ऐसा नहीं आता है. Where is the pattern of adenoplasm? And they will not come like this. So good. Surrounded by a desmoplastic tissues. Solid malignancy comes as pattern. Last you okay? पानी पियो. सुबह को मेरा भी नींद आता है, but I can't afford to sleep. पेशेंट आया एनीमिया लेके, ठीक है? जब एनीमिया लेकर आया है तो मेडिसिन ओपीडी में चला गया, तो मेडिसिन ओपीडी में गया या एन एनीमिया, सो ड्रॉप सेल्स, ड्रॉप सेल्स fully chromic tear, hypochromic teardrop cells, thalassemia, iron deficiency anemia, NRBCs, बहुत सारे NRBCs मिलते हैं. You don't have to see blast. Even yes. So we give a primary diagnosis of lobular carcinoma of breast. Oh no, just see. Now see the case. ये देखो. See this area. तो क्या हो गया? Bone marrow से lobular carcinoma of breast. ये देखो. So we did the IHC. So Herceptin, HER2 was negative, PR was positive, cadherin was. So we did 4 markers. Kindly call it clinically. जो हम लोग लिखते हैं, please examine the breast, right, to have a breast lump. तो लेकिन तो 2 बैलेंस है, थोड़ा ताकत कम. So this was metastatic lobular carcinoma of the breast. Exciting, isn't it? हम लोग जब ये देखा, we went and examined the lady and there was breast lump, but we pretended we had not seen. To become smart, and we wrote. Now we come to the next case. Okay, this is a absolute spotter. I just showed them the lymph node lymphomas. So the same case का bone marrow. Okay. So okay. Of course, if I had shown you the aspirate, you'd have got everything right. So these are the cells. So how do you differentiate a Gaucher cell from a pseudo-Gaucher cell? So what are the conditions in which you get pseudo-Gaucher cells? Myeloproliferative neoplasms, myelodysplastic syndrome, thalassemia, you get pseudo-Gaucher cells. So they look like this fibrillary onion peel pattern, all that language you can use. But the way you differentiate a Gaucher cell from a pseudo-Gaucher cell is enzyme assay. So, which enzyme assay will you do in Gauchers? Glucose cerebroside stains strongly for iron. Pseudo-Gaucher cells will be pass positive. So this is Gaucher. Of course, if you have the enzyme assay, you don't know. But similarly, after this is a beautiful case. Gaucher cells, so you see is 5. Who's TC, by the way? It's me. I've got my own step. So TC55 is a 5-year-old male child referred from pediatric department. Again, just like Gaucher's. Failure to thrive with a big spleen disease. Now look at this cell. I mean, this is something very rare. Huh? देख रहे हो? I am enjoying more. You know, 26. Okay, this is an exciting case. Another case. So let me first show you this case. 55-year-old male has sallow and massive Now see this case.
The case number 22, sir.
Case number 20. मैं देखता हूँ इसका पुनरावृत्ति। हाँ, Just what happens in a medical college, ये जो दो slide very fantastic diagnosis because जैसे diagnose होता है understand we've all gone through it. Okay? So I told my technicians, I'm going to give you the best of the category. Believe me, I rang them up and they told me yesterday. Please add this. So she added this, and yesterday I gave her this, and she was very excited. But see what we found. So Dr. UPHGCON Sharma, he was a general sahab in the army. He was my kabada. He joined also ESI as nephrologist. He called me, Tathagat, yaar ek itna bada spleen hai, renal failure patient ka, but people are missing out kala sir. Cachexia है, fever है 4 महीने के लिए. This is 100% काला सर. तो मैंने बोला तो what do you want me to do? नहीं तू आकर बोन मैरो कर दे. जो पैनसाइटोपिनिया हो रहा है और काला सर बताते मुझे. ठीक है बताते. और RKT39 सर एंटीबॉडी मैरो दे. So I took my 2 doctors with me, my professors. So चलो. सर ये तो diluted marrow है. So sir, stain particles आ गया. बोले नहीं यार ये stain party amyloid है. This is amyloid. So much of amyloid in the aspirate, which you don't see. हम लोग biopsy में देखेंगे, congruent करेंगे, पर in a leishman inside it is basophilic. Amyloid looks almost basophilic in the बोला यार ये तो कुछ गड़बड़ है ना? So see again, हैं? This is how happened. So what we did? We did 2 things. We rang our General Sharma and said, "कि sir, काला सर दूर की बात है. क्या बात कर रहे हो? नहीं सर ये amyloid. Are you sure? बोले सर renal failure हो रहा है. Kidney biopsy तो करो. So we forced him to do a kidney biopsy. Meanwhile, our bone marrow biopsy got ready. ठीक है? So this is the bone marrow biopsy. Now see the biopsy. देख रहे हो? This is the biopsy. See. ठीक है? So here in the biopsy you should see the perivascular spaces. The amyloid will be in the perivascular space. For example, see how nicely the amyloid has come. ठीक है? This whole thing is amyloid, right? So what did we do? So in the lab, you can do 2 things. You can do a congruent stain. You can have a polarizer. So you can attach a polarizer. Polarizer has got 2 parts. आजकल Olympus microscope में polarizer आता है. Bonus. So they will attach the polarizer to you. हम लोग के ज़माने में हम लोग को नहीं मिलता था. So now it comes. So you can ask for a polarizer in Olympus microscope. तो जैसे पोलराइजर आ गया आपने कॉन्ग्रुएंट देखा. हमारा पोलराइजर आया पर काम नहीं किया. ठीक है? So इसे what to do? So there is a stain called KMNO4 pre-treated congruent stain. So first I'll show you the congruent stain. So this is amyloid HNE. Now see the congruent. ये आ गया. This perivascular space on the These are the congruent places. Okay. Okay. These are your congruent. Light orange color stain, right? So we knew the congruent. Now we have to demonstrate birefringence. Okay. So our polarizer did not work. So this was one. Then see this area also. These are all amyloid, right? The entire thing is amyloid congruent stain, right? Perivascular spaces, right? Now what we did, you do a KMNO4 treatment and then do congruent. If the congruent stain persists, it is AL primary. If the congruent stain disappears with KMNO4, it is secondary to rheumatoid arthritis and various inflammatory disorders. So we did a KMNO4 pre-treatment. We standardized this. Our technician was very good, and our Congo red has actually disappeared. Clear? There's another slide. The Congo red has actually disappeared. Okay? But we were not convinced. Okay? क्या किया जाए? तो इतने में इसका किडनी बायोप्सी. Kidney biopsy हुआ तो Dr. Batra is in GV Pant. She is specialist in nephropathology. So she rang me up कि किडनी बायोप्सी मिला. Yes ma'am. तो मुझे बताया कि आपने क्या क्या किया. तो मैंने तब तक ये किया. देखो उसी बायोप्सी का मैंने CD 138 कर दिया. ये देखिए. देख रहे हैं? This is CD 138 positive, right? See here. ये देख रहे हो पूरा CD 138 nodular deposits आ गया. What does it mean? Right? Okay. So CD 138 आ गया. उसके बाद यहाँ पर एक तो स्लाइड जो मैंने मिक्सर आपके साथ किया था, ये है kappa. Now see the kappa. This is kappa. Okay.
Okay, somebody.
See the kappa, nicely stained. ये वाला. ठीक है. So we are getting kappa positive, CD 138 positive. See this. Lot of kappa positive, right? This one, this particular thing. So 138 positive, kappa positive. I told her, she said, I also got kappa and apple green birefringence. So what does that become? It becomes a light chain deposition disease. ठीक है? LCCD, आजकल उसको नहीं बोलते, आजकल monoclonal immunoglobulin deposition disease बोलते. The terminology has changed. So this patient was started on daratumumab. What is daratumumab? Anti-CD38. Anti-CD38. Daratumumab. So daratumumab पे regimen दिया. In 2 months time his spleen disappeared. He came to me with मिठाई. So पीछे देखा डॉक्टर यूके शर्मा भी मिठाई लेकर आए. मैंने बोला आपसे मिठाई लूँगा पहले. आप तो काला सर सोचे थे इसको. ले और किसी को मत पता. So this was a beautiful case. ठीक है? So that's why I combined both the cases, right? So today you are seeing a lot of variety of cases, isn't it? But to diagnose, the challenging thing is bone marrow aspirate. Bone marrow aspirate में that amyloid, that got us working. Otherwise we were thinking ये कलर कहाँ यार, kinetoplast कहाँ है? तो ये आ गया. Then that's it, my God. Okay. So this is done. Next case कौन सा नाम?
Sir, case number 9, TC 1520.
ये तो हो गया ना?
हाँ, ये हो गया सर.
26 था ना?
हाँ.
नहीं, ये okay. So now we come to TC 26 हो गया, right? Now we come to this. ये ना?
One page भी है सर last. Case number 9. ये वाला करेंगे सर.
TC 15.
हाँ.
Okay.
से ये.
This one. हाँ, TC 15. So next we come to TC 15, which is a 25-year-old male AIDS. So you are going to see a microorganism, है ना? Or not? How many of you diagnosed this? अच्छा, let's see, come. So again, nicely diluted marrow. हाँ, और हमें ढूंढना है क्या? So this is the problem in a diluted marrow. Okay. So I'm searching. Yeah, there it is. Seen? Okay. So eye sees what the mind knows. ये देखो, अब तो मिल गया. Now see. See. दिखाई दे रहा है? Histoplasma capsulatum. So where is the capsule in histoplasma? आ गया क्या? कहाँ है? उल्टा चला जा रहा है? अच्छा, उल्टा जा रहा है. Let me see. I'll see the better ones. आ गया? ये वाला. इसको थोड़ा सेंटर में. आ गया? So all of you could make this diagnosis? Yeah, you made it? Good. So what stain will you put in this? Yes. What else? Huh? Silver? Silver methenamine? है ना? So you'll put a silver methenamine and a PA stain. ठीक है? Now the question is, what is this capsule? Histoplasma capsulatum. There is no capsule actually, है ना? It's a formalin shrinkage, isn't it? So how will you differentiate this from yeah, here. यहाँ भी है? Yeah. So how will you differentiate this from a LD body? Standard question in LD. Okay? So it will be pass negative, silver methenamine stain negative. More importantly, in histopathology, what you will get? You will get a dot and a vacuolated area. The axoneme and the kinetoplast in an HNA section comes as a small rod with a dot. So dot rod bolte hain hum log, mimicking a capsule, some clearing area, that is LD body. So otherwise the size is almost the same, 2 to 5 microns. So dono ka size hai. So this is histoplasma. So whenever you get, now we used to do limited necropsy names. जब एड्स का पैंडेमिक स्टार्ट हुआ था तो आर्मी में ऑटोप्सी करना है because we have to give pension. This man has got AIDS and it is attributable to service. ये है ना, aggravated by service, attributed by service. तो उसको तो AIDS नौकरी करने के टाइम में तो मिला. The army is responsible for him getting AIDS. Whatever be the reason. Now he is not going to tell. He said I got a blood transfusion. He is not going to tell why he got AIDS. ठीक है? So we have to give him compensation. So autopsy करना पड़ेगा. So then you will get infected by AIDS. वो ज़माने में डॉक्टर लांजेवर का नाम सुने? Dr. Lanjevar had started the first autopsy and his technician got AIDS. So the autopsy was stopped. Then we started doing limited necropsy. That means the body is intact. We put a needle in the foramen magnum. We take out the CSF, lung biopsies, kidney biopsies, liver biopsy, and whatever little biopsies. And believe me, in all cases we got fulminant microbiome. We had a huge soft tissue tumor in the humerus. तो कैडावर है, बोले साहब ये तो ऐसे ही है, कुछ नहीं, मरो नहीं है करे. तो मैंने यहाँ से एफएनसी दिया, मतलब in the cadaver, limited. It was cryptococcoma. The whole thing was cryptococcus. CSF used to get Mycobacterium tuberculosis and cryptococcus in majority of the cases. So that time we thought that the commonest opportunistic infection is cryptococcus. It is wrong. It is Mycobacterium tuberculosis. So Mycobacterium and atypical are common. Then cryptococcus. Then in the lung we used to do biopsy. We used to get Pneumocystis carinii. आजकल तो बहुत दूसरा नाम हो गया उसका. I can't even pronounce that name. Pneumocystis क्या है? हाँ जरूर. तो हम लोग अटैक में carinii बोलते थे. ठीक है? Pneumocystis carinii. Boat shaped, those things. So this. So histoplasma capsulatum हम लोग को बहुत मिला. Then severe diarrhea. That was cryptosporidium. Now you will be surprised. Have you heard of a book called KD Chatterjee's Parasitology? KD Chatterjee's Parasitology. KD Chatterjee was a physician. He was never a pathologist. He was a physician और आर्चिकल मेडिकल कॉलेज कलकत्ता में धोती पहनकर आता था, मेडिसिन पढ़ाता था और his obsession in life was parasites. He thought that he had the parasites, so he became a master of parasitology. In that book of 1966, which my father was a very well-known neurologist. तो बताता था, तो वो किताब मुझे दिया कि हमने ये केडी चैटर्जी पढ़ा. So when I was doing my MBA in all those days, there was a footnote in human immunodeficiency and parasites. उस टाइम उसको AIDS तो पता नहीं था, 1966 बात. He said there is a AFB positive bacilli which are seen in immunodeficiency patients in the stool. He called it Isospora belli. Now, Isospora belli is seen in AIDS. This was identified in 1966. I'm telling you, this country is full of wizards. Only thing they don't know their wizards. He's written a book, he has mentioned Isospora belli, which we read in 1988 as stool of HIV patient में Isospora belli modified AFB stain करता. So that's why I put up this slide. This was actually a HIV positive patient, one of our soldiers who died, histoplasma capsule. Okay. Okay. So most of you made this diagnosis? No. ढूंढा नहीं. Okay. Where are we now?
Case number 10.
Case number 10. ये अंदर है ना?
Case 20 and case 20.
Case
30 on the slide and case 10.
Okay. So we are now in case 30 and case 10. So let's do it. Now transient ischemic attacks past 6 months in a 50-year-old male with weakness and pruritus all over the world. Now whenever you get a case like this and you're getting bone marrow, you think of a you think of a thrombophilia. Okay. So which are the myeloproliferative neoplasms which can be thrombophilic? Most of them, but particularly polycythemia vera. Right. So this is the bone marrow aspirate. So there we are. So it's a nicely cellular marrow, and what we see commonly is the megakaryocytes. Hai na? Straight away catch the mega. These are the platelet particles, and these are megakaryocytes. So the megakaryocytes here are characteristics. How are they? Normal or abnormal? Abnormal. Polycythemia vera has got normal megakaryocytes. The only MPN with an abnormal megakaryocyte is the primary myelofibrosis. ET and polycythemia vera have got normal megakaryocytes. Now, what is the difference? ET has got hyperlobulated megakaryocytes, but there will not be panmyelosis. It will be a normocellular to near normocellular marrow. Panmyelosis नहीं होगा. Panmyelosis किसमें होगा? Polycythemia vera and cellular phase of myelofibrosis. So ET is out, your cellular. Now the megas. Dyspoetic megas with hyperchromatic nucleus, with cloud-like nucleus, with angry-looking nucleus, with nucleoli, primary myelofibrosis. The megas here will be in clusters, will be polymorphic, but will be mature. So you'll have very large megakaryocytes, you can have medium size, you can have small size, so polymorphic megakaryocytes, but they are mature in loose to tight clusters. Whereas the primary myelofibrosis are dyspoetic, hyperchromatic, cloud-like megakaryocytes in tight clusters. And the ETs, no panmyelosis, normal cellular marrow with hyperlobulated stag horn. So that's the reason MPN will always be asked the question. And then you will be asked the mutation panel, which I'll not tell you now. So this is the megas in a panmyelocytic marrow. And then the biopsy, simple biopsy. So how many have got it wrong? Right, so sabko milega. How many have got it wrong? Good. So here, so what do you think this marrow is showing? And what other things you'd like to do in this? You would like to do a reticulin smear. Okay? What? You want to see fibrosis. Now why fibrosis? Spent phase. The spent phase of polycythemia vera can have a lot of fibrosis. So reticulin stain is a must. So this is a patient who has got splenomegaly. Suddenly his spleen छोटा हो रहा है. छोटा हो रहा है. इसका fibrosis हो रहा है, and he is going into pancytopenia slowly. From a hypercellular, he will go to pancytic. So that is the end stage. So these are the patients who can produce vaso-occlusive crisis, and they produce a syndrome which in the liver is called Budd-Child syndrome. Extra hepatic. Okay. Yeah. Yeah. Okay. Next. TC 61. Now this is a fabulous case. Now if someone has got this right, I will give him a chocolate. हालांकि मेरे पास chocolate है नहीं. So this is a very good case. So this is 45-year-old female with severe pallor and moderate splenomegaly. So cellular marrow number 1, right? Now see the cells. Hyper view. देख रहे हो? See the cells. Bilobe, trilobe, multilobe. सब लोग देखे ना ये सब? Now see the fun. Better area. Now see this. देख रहे हो? Okay. Come to higher power. See this cell. What are these cells? Anyone? क्या बोला? See. किसने कुछ बोला था भाई? बोलो. मान जाओ. Early. Absolutely correct. This is pure erythroid leukemia. Okay? This is not megaloblastic. So, what is the diagnostic criteria of pure erythroid leukemia? More than 80% erythroid and more than 30% are no erythroid. So, these gigantoblasts. Okay? Have seen? You get a similar picture in CDA type 2. Don't call it CDA congenital dyserythropoietic anemia type 2. This is acute leukemia. Okay? So, clinical scenario is very important. So what special stain will you do? And what cytochemical stain and what IHC stain will you do? Cytochemical stain? Pass. You do pass. And IHC? See, this is a gigantoblast. Take note. Take note. So much of this. Earlier days, erythroid leukemia had a MDS phase. So erythroid leukemia used to have a MDS phase and then it should migrate into this thing. Now, if you see the latest classification, the ICC classification has placed this as AML MDS. ICC does not consider it as erythroid leukemia. It considers because majority of them are TP53 mutation positive. So, AML MDS with TP53 mutation. Whereas WHO says, yeah, conventional erythroid leukemia. Because WHO is made by pathologists. ICC are majority are clinicians. So that's the difference. Have you seen? So this is acute erythroid leukemia. What are the IC markers or flow markers? CD. Yes, glycophorinase. CD235. Very good. So now we come to TC 51 and 31E. So you saw this. Now see this. This is the standard cases you will get. What is the history, madam?
Sir, 55-year male with massive splenomegaly and anemia with leukocytic.
Yeah. So when you see this slide, what is the main thing you see? Yeah, these are the cloudy megakaryocytes. Okay, these ones, right? We'll show you some more like this. See this hyperchromatic one? See? So the clinical scenario, what? Anemia. Myelofibrosis will not produce that much of pancytopenia, but it will produce massive anemia. Big spleen, myelofibrosis and anemia. You might have a normal TLC also in the initial phase, even the platelets will normal. But severe anemia. So whenever you're having severe anemia with a big spleen disease, it is myelofibrosis. Then you get all these megakaryocytes in clusters. Let's see further. Yeah, like see this? These are all you saw the polymorphic megakaryocytes in polycythemia, now see these megakaryocytes. See the difference? hyperchromatic, right? So these are the, so American board question में पूछते हैं, which in the following situation shows abnormal megakaryocytes? What is that there? ET or primary myelofibrosis? For all four. So it is primary myelofibrosis, okay? And this is the biopsy. Already fibrosis is set in. So you like to do a reticulin and a VG stain, है ना? You want to see the type of fibrosis, है ना? Okay. So this is what we see. Look at these disparting megas. Yeah. Clear? Right? So you'll do a VG stain and a reticulin stain, and you can diagnose this as a primary myelofibrosis. Which mutation you'd like to do? So we have standardized an MPL mutation. So JAK2 B617F is seen in more than 50% cases of both ET and myelofibrosis, and in 98% cases of polycythemia. The other mutation is MPL mutation, and the third one is Cal reticulin 1 and 2. So you have to do all this, right? Okay. Now we come to the next case. Okay, this was an autopsy which I have done. 112, no? So this is very, anyone with a difference in opinion? This is clear, no? This is just true because, yeah. So all of you know this? Yeah? With plasmablastic morphology, है ना? Because the nucleus has become central also with a nucleoli, right? And the biopsy, of course, is very standard case. The reason is this patient died. He was resistant to all sorts of therapies, so it was an interesting case. So how does a plasma cell involve the bone marrow? It can be nodular, it could be interstitial, it could be diffuse, all three, है ना? And this is the biopsy, this is diffuse. So the question here is, what do you understand by syncytial sheets or syncytium? So a normal plasma cell can have plasmacytosis also. You can have plasmacytosis 30% at glucose also. So the moment 3 to 5 cytoplasms are coalesced together and they're invading as a broad structure, that is called syncytial sheets. So that is a hallmark of a malignant plasma. आप जितने भी IHC बोल दो, ये बोलो, वो बोलो. Finally, general pathology. सब मिलकर invade कर रहे हैं. एक साथ single cell नहीं कर रहे. एक साथ 3-4 सेल मिलकर invade. So that is called syncytial sheets. Okay. What are the IHC markers in myelomas? So 38 and 138 are seen in both normal plasma cells as well as in neoplastic. But the 138 is more intense in neoplastic. And CD38 is seen in activated B cells, activated T cells, hematogones, as well as normal cells. That is one. Aberrant expression is a sign of clonality. तो अगर आपके पास कापा लैम्डा नहीं है क्लोनैलिटी के लिए, अगर आपको CD38 और 138 में से एक भी पॉजिटिव आ गया और अगर आपका CD117 which is c-KIT और CD56 दोनों में से एक भी aberrant mutation आ गया, मतलब IHC, you can straight away say these are clonal plasma cells. So the aberrant IHC markers in a plasma cells are a sign of clonality. We had a very rare case, I don't know whether I wrote this case. A patient came again with weakness and all that thing. So bone marrow किया, bone marrow was dilute, ठीक है? But उसको मैंने flow कर दिया. When I did a flow, it was just CD13 positive. It was just CD13 positive, which is a myeloid marker. CD33 negative, anti-MPO negative, all the myeloid markers negative, all the B lymphocyte, T lymphocyte negative. And we were wondering what this is. Just 13 positive. मैंने बोला ये तो समझ में नहीं आ रहा. So I did the flow with extra antibodies and I put a 56. 56 became positive. मैंने बोला यार it is acute undifferentiated leukemia. Same case. Acute undifferentiated leukemia with any one of the myeloid markers positive and not behaving anyway. It could be anything. तो मैंने सोचा कि बड़ा rare case है, case report दिखती है इसका. Then what happened? The patient was having severe problems. I said, यार CD56 myeloid में तो मिलता है, 13 मिलता है. I had forgotten to clearly see the side scatter CD45. The most important scatter in a flow is the side scatter versus CD45. Leukocyte common antigen site. Low side scatter, bright CD45, lymphocyte. Medium side scatter, not so bright CD45, monocyte. High side scatter, moderate CD45, granulocytes. This is a fundamental of flow. And this was moderate side scatter, CD45 negative. Guess what? तो मैंने जब AML का पैनल डाला था उसमें 38 130 तो डालता नहीं है, खाली 13 33 में से 13 आ गया. फिर एक 56 था, T पैनल में 56 रहता है, TN के पैनल में 56 was मैम, this is something wrong. So I put the 38 138 again, bright positive 138 and 38. I was dealing with the plasmablastic myeloid. Why? The mistake I made, I forgot to see the properly. अरे चलो चलो antibody देखें क्या क्या है. Side scatter CD45 is the most important scatter diagram in your flow. उसी में से आप सब कुछ diagnose कर सकते हैं. CD45 negative is a plasma cell. The brightest 138 positive in the marrow is a plasma cell, and they are 56 positive, 13 aberrant, and CD45 negative. तो आजकल इतना टेक्नोलॉजी है एक साथ, इतने जमाने हम लोग पुराने कितने मिस्टेक्स की. Now there are so many and still we are making mistakes and we are rectifying. Every day we are learning. Next case.
So case 14, beyond 435 and PC 45.
Case 14.
जी.
ये 435 है.
हाँ 435.
I'm not sure.
ये हो गया सर.
Okay. Now see this case. ये भी है.
हाँ ये तो इससे.
45 46 पे. ये 40 अलग है. ये अलग है. 45. Yeah. Now see this case. Now this case got published accidentally in the American Society of Hematology. Now how it got published? Let's have a look at this. This came as an acute leukemia, right? तो हमारे पास आया BALL करके है, तो द मेडिकल ऑन्कोलॉजिस्ट बोला सर BALL है, हमने मैरो कर दिया है, तो बाहर का स्लाइड तो हमारे पास है नहीं, इसलिए मैंने मैरो कर दिया, इसका ट्रीटमेंट जल्दी से स्टार्ट कर दिया. ठीक है. सो BALL, हाँ यार ब्लास्ट तो है, वी आर सीइंग ब्लास्ट, है ना, यू सीइंग द ब्लास्ट, ब्लास्ट तो है, बट देन आई सॉ दीज. Okay, let's see further. Now you'll see, slowly I'll show you the cells. Now see this. See these areas. Blasts, right? Okay. So it was going as ALL. Now see this here. See this area? See this area. What do you see? Anyone? So what's the history? The history was retroperitoneal mass with pancytopenia in a chorial site. These are rosettes. This is neuroblastoma, and those were neuropils. So when ALL, it was misdiagnosed. So हमने फिर इसका biopsy किया. Anyway, just see the marrow. So these are the neuropils, right? See again rosettes. These are all the rosettes. Okay. So what are true rosettes and what are false rosettes? So in neuroblastoma you get true rosettes, isn't it? Around the neuropil. So we did a biopsy. Biopsy was very much like fibrous tissue biopsy, but yeah. देखो, these areas, they are round cell tumors, correct? Around neutrophils. ठीक है? All these are round cell tumors in rosettes around neutrophils. So we did a synaptophysis and we did a NSC. They are all specific innodes and they were strongly positive. So this was a neuroblastoma. Now many times, if you don't get the history, you are likely to overdiagnose and misdiagnose this case as leukemia. And it came as a DLL. Okay. Next case is 46. Now few spotters for you all to get full marks. So case 46 is a female CRF, chronic renal failure, multiple long fractures, long bone fractures, bone marrow dry tap. Seen? What is this? Renal osteodystrophy. Hugely thickened bone with loss of Haversian canals. This comes with pancytopenia. So chronic renal failure means because of the phosphate calcium ratio being altered. These are all renal osteodystrophy. ये देखो, देख रहे हो bones? Hugely thickened. इसमें fracture होता है ना? And then you will see how shaped lacunas going inside. Osteoblastic activities ज़्यादा हो रहा है. But more thing is this thickened thing. Marrow कुछ है नहीं. So कोई बोलेगा ये plastic anemia है. नहीं, ये CRF का ये because of the phosphate and calcium का distribution. This is renal osteodystrophy. Next case, which is that one? 23. हाँ. How many of you have diagnosed this? H9199, high grade fever for 1 month. सब लोग ने देख लिया? Kala-azar. All of you seen? Give her a good hand. Good. At least some of you have seen it. So this was going as a diluted marrow. I was telling you, I was at run of Kutch. और मैंने इसको पकड़ा इसको. So एक मेगाकेरोसाइट मिला. So I have to search for it, but I hope I get it. How many else have got it? और किसको मिला? So 3 or 4 of you have got it. So see, everyone was rejecting the slide as a diluted marrow, and why? Rightly so. ठीक है? Till we saw this. Now see. Now see this area. अरे पार्टिकल मिल गया, थैंक गॉड. हाँ ऐसे. एंड देन पार्टिकल के अंदर ये देखो. देख लिया? भरा हुआ है. और है? और कहाँ चला गया? आ गया? अभी? So, कहाँ गया? ये these ones. So these are regular. So I went a step ahead and I did a GIMSA on the bone marrow biopsy. This is a GIMSA. There was a bone marrow biopsy, उसमें कुछ लग रहा था. Now see the GIMSA on the bone marrow biopsy. ठीक है? How many of you can see the LD bodies on the GIMSA? These are the LD bodies of the GIMSA in the bone marrow biopsy. Now see. दिखाई दिया? These ones. So when you get a thin section, and you are convinced because we had a diluted marrow, एक जगह मिला, biopsy किया, GIMSA किया, एक जगह. So we gave him liposomal amphotericin. These days you don't give antimony, है ना? Who discovered antimony in the treatment of Kala-azar? He was a Brown, so he was not given a Nobel Prize. Indian physician of the highest order. बोलो कौन? Doctor, bolo, very famous doctor from the Calcutta Medical College who discovered antimony stevogluconate, and thousands of people from Bengal and Bihar survived because of this man. Nominated 4 times for Nobel Prize, didn't get it. Dr. Brahmachari. I forgot his first name. Just check, anyone Google? Indian doctor who has discovered antimony stevogluconate. This is the man. So many people survived. There was a Black Death. Was the one in there. Okay? So this was healthy body, right? एक बार check करो. Indian doctor who discovered treatment of Kala-Azar, that is antimony stevogluconate.
Shri U.N. Brahmachari.
U.N. Brahmachari. See, Brahmachari. Dr. U.N. Upendranath Brahmachari. Upendranath Brahmachari, one of the most brilliant doctors of his time. He is very famous. उसका अगर हिस्ट्री पढ़ोगे, भरा हुआ है हमारे इंडिया में हिस्ट्री, पर किसी को नोबेल प्राइज नहीं मिला. ठीक है? So unfortunate. So we come to the last 2 cases. 4343 कहाँ पर है ये? So see this case. What is the history, ma'am?
Multiple cutaneous lesions all over the body and retroperitoneal lymphadenopathy. CBC shows absolute lymphocytosis. Case
Okay.
number 17.
See this? Cellular bone marrow, isn't it? So what do you make out? These are all the lymphoma cells. These are all the lymphoma cells. Okay. Now see again. Yeah, hand mirror cells. Correct. Yeah. Now see. These are the cells. Right? Plenty of these cells. These are myelocytes. Okay. But this is the erythroid. These ones. Okay. So what do you think? So hand mirror cells are non-specific. You can get in ALL, you can get in peripheral T cell. So we did a biopsy, of course. So जब biopsy किया, so these are the nodular aggregates. Okay? Nodular aggregates, right? See more. Here. Nodular aggregates. So this was a peripheral T cell lymphoma, actually an NK cell lymphoma, which has involved the bone marrow. So many times you can see this. उनका lymph node biopsy तैयार नहीं होता, ISC तैयार नहीं होता, ISC reagents available नहीं था जैसे गवर्नमेंट में होता है. इतने में bone marrow आ गया. So at least you can do this thing, है ना? So we did a CD3. Our ISCs are separate, ना? We keep it separate. हमने CD3 कर दिया. CD20 negative, CD3 positive, 56 positive. मैं बोला यार TT NK cell lymphoma, TTT negative था. तो moment TTT is negative, ALL is out. Simple test. TTT is a nuclear stain. IHC में आराम से कर सकते हैं. TTT negative, all blasts are out. So you are dealing with lymphoma. 56 positive, 3 positive, NK T cell lymphoma. You become a hero overnight. Next 2 cases and then you finish.
नहीं सर.
और भी है?
हाँ सर, अभी हम 18 पे पहुंचे.
अच्छा, my God. This is bone marrow 2.
Bone marrow 2 and TC10X.
See this case again. So we had absolute lymphocytosis in the peripheral blood, and this is the marrow. What do you see in the marrow? Blast-like cells, है ना? So it is so easy to call it ALL. Never do it. Why? Because you are seeing mature lymphoid cells also. So they are not blastic. लग रहा है blastic. This is erythroid. These are the mature, the chromatin. So whenever you see a blast or you think it's a blast, पूरा लाइट में कभी मत देखना, चाहे हिस्टो में चाहे हेमेट, कंडेंसर लो, इल्यूमिनेशन लेस. The moment you take it right, you will be blind. Everything will look blast. तो इल्यूमिनेशन को कम कर दो, लाइट को, और कंडेंसर को नीचे कर दो. The moment you see a multicolored chromatin, black and white, not black and white, pink, light pink, dark pink, light pink, light pink. So they are heterochromatin, euchromatin. It is the sinus, it's the commonest or the surest sign of a mature lymphoid cell. Absolutely homogeneous blast. So go by chromatin. Don't go by size, don't go by nucleoli, go by chromatin. So ये जब हम लोग ने देखे, ये सब mature chromatin थे with angulated cells, right? This was mantle cell lymphoma. So this was non-nodal mantle cell lymphoma with a leukemic spill. So we did a biopsy, and in the biopsy, we did a cyclin D1. Got it? Now cyclin D1 is CCND1 mutation, which is seen in translocation 11-14 mantle cells, right? 14 is immunoglobulin heavy chain. 11 is CCND1. So CCND1 or heavy chain का जो translocation 11-14, that is the mantle cell lymphoma. So this is the hallmark. So हम लोग cyclin D1 करते हैं. Cyclin D1 में क्या मिलता है हमें? Nuclear stain. ये देखिए. This is the bone marrow, right? So this is called interstitial involvement. Interstitial means normal marrow के बीच में abnormal cell जाता है. So you have nodules of lymphoma cells, you have diffuse, and interstitial, like in hairy cell leukemia, mantle cell lymphoma, you can get all types. So in between the normal, the abnormal are creeping. Okay? Now see this. The focus नहीं हो रहा. Oh, sorry, उल्टा गया. Communist. Here you are. These are nodes, nodular and interstitial. So you got all three. You got diffuse, nodular, interstitial. So these are your lymphoma cells. So whenever you have a blastic population of cells in the marrow or in the biopsy, how do you do it? So if the blasts are there and you're not sure whether it is ALL, is it a mantle cell lymphoma blastic phase? Is it a high-grade lymphoma blastic phase? Is it a Burkitt's? All these have the same morphology, blast line. तो क्या करना है? आपके पास TDT है. The moment TDT is negative, lymphoblastic lymphoma leukemia is out. So you have removed one crutch. ALL को निकाल दिया. TDT negative है. क्या रह गया? Mantle. Cyclin D1. Commonly available nucleus state. Cyclin D1 negative. Mantle out. फिर रह गया क्या? Burkitt और दूसरा क्या रह गया? हाई ग्रेड लिम्फोमा, द डबल हिट लिम्फोमा. तो उसको छोड़ो, वो सब फिश है. Burkitt, most important, starry sky pattern, tingible body macrophages along with blast-like cells. They are TDT negative, CD34 negative, BCL6 positive. This is a germinal center cell. CD10 positive. BCL2 negative. क्यों? अरे टेंजिबल बॉडी मैक्रोफेजेस देख रहे हो, एपोप्टोसिस हो रहा है. BCL2 इज एंटी एपोप्टोटिक ना, समझ गया? दिमाग लगाओ. सो बर्किट लिम्फोमा इज अ जर्मिनल सेंटर सेल. जर्मिनल सेंटर का मार्कर क्या है? BCL6 CD10 दोनों पॉजिटिव है. इट इज नॉट अ ब्लास्ट. TDT नेगेटिव है, CD34 नेगेटिव है और BCL2 remember. So that is Burkitt. So whenever you got blastic morphology, use your ontogeny. Read ontogeny and you will see flow, IFC. These are all कुछ नहीं है. There is no rocket science. Just understand ontogeny, how a cell develops. Okay. So this is mantle cell lymphoma, right? Next, ma'am. Now we got 3 more cases and then we'll finish.
Case number 19.
Will you give me a cup of tea after this one?
Yes, sir.
Okay.
Sir, actually tea is ready. We can.
दो केस है. We'll finish करो. 2 केस. कौन सा नंबर?
Case number 19, sir.
That is BMA 3 and TC 32.
BMA 3.
Okay.
55-year female with bicytopenia and repeated URTI.
Oh, now see this. 55-year-old female
With bicytopenia, easy fatigability and repeated URTI.
Now see this. This is case 19.
Case 19.
BMA 3.
BMA 3 and TC 32.
ये वाला ये मेरा वाला है ना तो कंफ्यूजन तो okay now see this. Now the first thing you see in this case is a bit of a diluted marrow, but here we are getting particles. What are these megakaryocytes? Yeah, this is hypolocated, right? And fairly cellular. So bone marrow is not hypercellular. Yeah. Have you seen this? And loose clusters, right? Okay. Then we do a biopsy. And the biopsy. Yeah. So how many of you got it correct? This is the biopsy, right? See the cellularity, 70 to 80%. Middle-aged or elderly, मतलब middle-aged lady है. And these are all the unilobated 5q syndrome. So 5q syndrome is one of the very nice MDS to be diagnosed in 55 to 60-year-old ladies. इसमें refractory anemia होता है. The medicine is lenalidomide. So it's a hypomethylating agent. So lenalidomide क्या करता है? इसको एकदम ठीक कर देता है, ठीक है? So it is one of the nice MDS to get. But if the 5q is associated with a TP53, then the prognosis is bad. Okay? So you have to do a panel of. So we got a panel of fish. जब हम लोग MDS करते हैं ना, diagnose देते हैं, we make the panel for them. कि आपको अगर MDS करना है, तो the following 8 mutation panel आपको करना है. ASXL1, IDH2, TET2, SF3P1. These are various mutations. So we give them an 8 panel mutation for MDS and we give them cytogenetic panel. And then we tell them. So it's an isolated 5. It's called isolated 5q syndrome. The isolated 5q minus syndrome is a very nice MDS and can be treated with lenalidomide. ठीक है. और कितने केस हैं मैम?
4 cases.
Now the spotters, है ना? Tired? Quickly. 20. कहाँ पर है मैम?
Sir, case 1845.
इसमें यहाँ पर है.
Yes.
See this case. If someone has missed this case, it is not acceptable. Clear? Anyone? Such a lovely granuloma. Can't miss it. So this is a spotter, right? Next case. Case 44, na? 44. Yeah. How many of you have diagnosed this? Tell me. How many of you have diagnosed this? This is severe anemia, renal failure, and splenomegaly in a 10-year-old male. Anyone? See the needles. Hereditary oxalosis. We found the same needles in the urine also. Okay? Incidental finding. But देखो, so many of this. So these are spotters. तो एक तो यहाँ मिला. Hereditary oxalosis. ठीक है? Here. हाँ, नीचे भी है. ऊपर? I don't know. हाँ, ठीक है? So hereditary oxalosis, ठीक है? So just a teaser for all of you. But you all don't see this case, so I thought let's put some for you.
Sir, case 22, TC31.
So that is plasmablastic myeloma. You have seen that case. So the last case is case 23. Now see this case. This is the final. Okay. Now please concentrate. 2727.
Last second last.
इसमें क्या क्या है? अच्छा, तीसरा, ठीक है. So this is a peripheral smear, right? Now this patient has come to us without any history. ठीक है, concentrate. Patient has come without any history. And the JR comes running to me, sir, AML case hai. I am about to go home at 5 o'clock. ठीक है ले. And see what we see, an AML case. So she sees all these blasts. And this is where all of you will make mistakes. She also presumed or imagined that she saw all rods. So sir, all rods mil gaya, ye mil gaya, AML hai. Which happens when, we are also looking for a cup of tea, we are getting hypoglycemia. So you can make a wrong diagnosis at this stage. Okay? So this is the last case. So what do you think it is? Anyone? Blasts? Lymphoma? AML? Spillover? Anything else? What is the first thing you see? Nucleoli? Mature cells or blasts? To reduce the light, reduce the potential. And you see some of them are mature. So I told them, if I AML nahi hai, you will see the patient tomorrow. You saw the patient. Itna bada spleen. Which AML will come with such a big spleen? He came to me, sir, मेरा तो कोई problem नहीं है. तो आया क्यों? तो सब भूख लग जाता है जल्दी. तुम्हारे तो देखे तो सही इतना बड़ा स्क्रीन. Clinician is not seen. ठीक है? तो then I said, AML, which AML, and that to all rods, no all rods. Which AML is such a big screen disease? What was it? So which is that CLPD which looks like a blast, which comes with big screen disease in 3 months? So angry with me, that is not good, unlike other CLPD. So, see this. ठीक है? Light इतना ही है ना?
Light इतना ही है sir.
अच्छा. So SMZL, yes, big spleen disease, very correct. However, we like to see some villous lymphocytes and all that thing. Now, they don't look like the AML blasts, See this, almost blastoids. So I knew what I was dealing with. Okay? PPL. Now this term has been out by WHO. ये बोला again ये pro lymphocyte leukemia और कुछ नहीं है, ये mantle cell का ही कोई family है, just like hairy cell variant. So hairy cell variant PPL, so we did a flow. So flow, strong CD20 positive, TDT और 34 सबसे पहले लगाया. TDT negative, 34 negative, CD117 negative, anti-MK negative, 1330 negative. जान बच गया. Then I put the CLPD marker, strong CD20 positive. So whenever you see a side scatter and a CD19, the blast window is here. The lymphoid window is far away. It is bright. So the moment you see side scatter CD45 or CD19, इतना दूर जा रहा है तो ये है lymphoma. ये blast नहीं है, leukemia नहीं है. That blast CD20 positive, FMC7 positive. So FMC7 positivity negates a CLL. CLL तो सोचिए ना, CLL ऐसा थोड़ी होगा इतना बड़ा स्क्रीन. So we gave a diagnosis of BP, and the patient has now been put on specific treatment. But this is an aggressive CLL. So with that we come to an end. Thank you very much for your patient hearing. I hope you all enjoyed the site. Good.
Very interesting. I just take 2 minutes.
Yeah, sure.
Like government में government sector में चलती है.
Actually, I showed them 25 lymphoma cases there. Unusual cases I showed them. Because you get, so I showed them the normal as well as the unusual. Because आता है, cases आता है. What we say is unusual because we are not diagnosing. Unless we know the normal, it's impossible to diagnose that.
Must have been very exhausted.
Nah.
2 hours session in the morning and then again.
No, 4 hours there.
4 hours.
Lecture भी था ना. All sorts of things होते.
But really it's very nice.
हाँ.
Nice battery cases.